If you do mind talking to your professors, if they have an undergrad that's in marketing and pre-med, that would be perfect.
Okay, will
All
do.
right.
Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. How are you?
I'm great. You seem to be pretty busy nowadays. Obviously you've got your full-time job and now you've also got your Billy Madison hat. You're going back to school.
Yeah. This was a B school weekend. So that for that it's Thursday all day, Friday all day, Saturday all day. So we're recording on Sunday the 29th, and we'll be dropping this episode in a couple of weeks. But yeah, school's really great.
So do people in the executive MBA program actually call it an MBA? Because people have told me that Chuck is going after his MBA. I'm like,
I
is that what they
it's
call
it,
it?
it's funny you asked the question. They do call it the IMBA, which I never always call it an executive MBA, but I guess that's too much of a mouthful. So they call it the IMBA.
Well, I mean, I give some of our trainees a hard time if they come in saying ORIF. Say, to
They
me, an
do
orthopod
say
doesn't
that.
say ORIF.
Or
Say
foosh.
ORIF.
Do you
Or
say
Foosh is
foosh?
Foosh is the other one. I am not a fan of Foosh. That's actually one of the things you can't say in my clinic. There are a few phrases, some of which I can't say on air, that you're not allowed to say in my clinic. Foosh and ORIF are two of them.
I have a feeling that this is going to resonate with some listeners. Yeah, I am not an orif or foosh. I don't like those things. I mean, I don't know why ORF is better, but it is. It's clearly better.
Anyway, I thought you'd have feelings about this. So we're either gonna people. It's gonna be polarizing. They're either gonna be with us or against us. It's fine. I'm sorry you're wrong if you actually say ORIF.
Yeah, so business school is it's kind of crazy. I think I don't know if we talked about it on the air, but I've wanted to do this forever. So I am a little bit older. I'm not the oldest, but I'm older and in the class. But it's great. So these last 3 days, basically the way it works here at WashU Olin School of Business is you have a 4.5 hour class in the morning and a 4.5 hour class in the afternoon. You do that for 3 days, and they go beyond one weekend. So this weekend we did accounting. And we also did business analytics, which is really looking at HBR cases and learning how to know what to analyze and then how to do the analysis. The hard part is not doing the analysis, is figuring out what to analyze and how to gather disparate pieces of information and bring them together for a statistical assessment. It's very cool.
Now, is your MBA one that has a specific focus, like a healthcare focus, or is it a more generalized, you're shaking your head no.
Yeah, I was going to verbalize that too. Yeah, I did not want a healthcare focus. I wanted the kind of the whole thing. And so this fall, it's those two classes. It's um, and accounting, business analytics. Yeah, those three classes for the fall. And so far, it's been really awesome.
And have you found it hard to get into the assignments given that they don't have a healthcare focus? I mean, because obviously we're talking about industries and spaces that you have not had a particular professional interest in.
Yeah, so far they're all 100% applicable. Like marketing is obviously applicable, accounting clearly, and then the business analytics is really, obviously you and I aren't reading HBR articles at work, but the concepts of kind of how to think about things, how to apply mathematical assessments, and then how to take what you find and present it and share it and convince people is really great. And so I think that everything I do will be applicable. And it's just interesting stuff to me.
Are you the only clinician in the program?
No, I am not. There are uh, two other full-time clinicians, one neurosurgeon at WashU and one plastic surgeon. There's a internal medicine doctor who does a lot of research, and there is a two full-time PhD like research folks. There's some clinical grant managers, and so there's probably a quarter of the class. There's about 30, 33, 34 people in the class. About a quarter of the class, maybe a little less, has some type of medical tie.
And of the, I guess maybe the surgeons, what's the timing of this in their careers and kind of their overall intentions? Obviously don't say names, but what's their goal?
Um, For the probably they're definitely younger. I think they're both in their early 40s. I think it's a kind of it's a source of interest. I don't know that either of them have specifically stated that they thought this would take their career in a different direction, maybe help them in their current status, maybe give them something to re-engage with. Yeah, I actually haven't asked that specific question. That question gets asked of me all the time, but I haven't specifically asked that question. But it's really an interesting thing. I don't think it, and I'll know more as I go along or develop stronger feelings. I don't think an MBA is for every doctor, obviously, but just the learning process at my age, when you get old, is fantastic. Like it's amazing. It's really great.
It sounds fun. I always joke about wanting to do it, and Tiffany's like, "You better not actually do this. Just you wait." But is there anything in particular that you thought about in terms of timing? I don't know whether it was more of where you were professionally or kind of the situation with your kids, or
Yeah, it all sort of came together. I've been looking at this particular program probably for 5 or 6 years, and it just felt like I couldn't pull it off in the past. I'm an empty nester now, as we've talked about. That definitely helps. My wife was in agreement for a lot of reasons, so that helps. I honestly think mid to late-ish 40s is probably the right age, which is older than a lot of my classmates. I'm certainly not trying to say anything negative about my classmates, but there is, for this particular program, the executive program, there is a critical life experience that that brings a lot to the class. And hearing different people in different industries talk about their challenges and their opportunities and their competition is part of the great, what's so interesting about it. And so I think you got to have done enough to know the problems of your industry and to know what you want to accomplish to really get the most out of it.
well, it sounds like an amazing experience. I look forward to seeing you go through this journey and hearing your reflections on it. It's gonna be a lot of fun.
Yeah, I have a big accounting test that I need to get done. It's open book, but it's individual. There's an honor code. The professor estimated 15 plus hours to get that done. That's the test, and there's homework and there's a marketing assignment. So it's going to keep me occupied, which I guess is good.
15 hours for you is probably, well, the assignment's 15 hours for you. That's probably what, I don't know, 6 hours, in between running two rooms and having meetings.
It's funny. I don't know. I think I'm an average accounting student, so it'll be really interesting to see
I don't think you've
what that
ever been
is.
average at anything, Chuck, so I'm not worried.
Well, here's one for you, and I've been given advice on this. So for this particular test, there's part of the test which is to go for a pass. This pass fail, which is the right way. It should be pass fail. So you can do 80% of the test and get a pass, or you can go for a high pass. There's no honors or anything, so it's just pass, high pass, low pass. You can go for a high pass and do significantly more work, another 5 to 10 hours. And intrinsically, I'm like, of course I'm going to go for the high pass. And the practicality is I need to modulate reality. And I don't think I can do it. I'm still toying with it because it feels wrong not to. But that's really interesting. Like it's not who I am.
Well, I don't know if it's one of those things where, the people who get the high pass, maybe their names get passed on to other employer. Like if you were maybe not somebody who was in the position you're in, it might matter, like, but I guess P equals MBA at the end of the day, right?
That's true. But as you and I have talked about it, and I know you're not suggesting otherwise, it's not just about the letters, right? I am doing this because I am super interested. And there's no doubt that the exercise of doing the work makes you better. And then there's the cognitive dissonance. I think that's the right expression, which I'm feeling by even thinking about not doing it. And judge me if you will, listeners. That's just reality.
I guess we'll check in and see which one you got, which assignment you completed. We're going to do a details episode today about a topic that I think a lot of people have encountered. But before we do that, why don't we jump in and thank our sponsors at Practice Link?
Absolutely. The upper link. I'll start over on that one. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
All right. I think we have a great case to discuss.
Well, yeah, no, I think the case is good because it leads into a pretty good details type episode. I know that when we saw people in Toronto, people have asked for more kind of technical detail episodes, and I think this one is chock full of them. So, this is somebody who is somebody who is in their kind of let's say 30s or 40s, had a very large piece of glass, come down on their forearm, and you've got a laceration that's about 5 centimeters proximal to the wrist crease, transverse, stays on the volar side, doesn't go anything dorsally. No fracture, remarkably, on X-ray, and lacerated everything on the volar aspect of the forearm. Every tendon, including the palmaris, which was present. And then, for the purposes of this case, this patient actually had a revascularization at an outside facility, and then ended up with me. So that's one wrinkle we could talk about. But fortunately, the fingers are perfused, has a good attitude, good support. How do you kind of think about this, what we call in America a spaghetti wrist, and what I'm told you call in India a full house, from my experience there? How do you think about this injury as you see this patient, either if you were to get called from the ER or whether it's in, this patient never comes to the office, but this time actually came to the office?
Yeah, well, that was going to be my first point. It's interesting what occasionally we do electively, but the vast majority of the time is not an elective procedure. And this one certainly fits that category. I recently did a perilunate electively that was reduced at an outside hospital, came to see me like 10 days later. And that obviously is done electively if the reduction is accomplished in the ED.
Did it stay reduced?
It stayed reduced. Yeah,
Oh, wow.
stayed reduced. It actually, what was interesting about that case, not to go on a tangent, but what was interesting about that case is it was so I got to it about 2.5 weeks later. It was challenging to get the scapholunate reduction where I wanted. It wasn't a simple maneuver. So that felt like more work than I would typically have seen. But otherwise, look, it was nice doing it electively for sure. So this is fascinating. So it sounds like probably not a hand surgeon, maybe a vascular surgeon at a smaller emergency department may have taken care of this and done the revasc. And that brings a whole nother bag of worms, I guess, because you really have to make sure you take care of that. Obviously, you're going to, but that has to be priority number one. Not that you can't redo the repair, but that's really important.
Yeah, so this patient had revascularization, radial and ulnar arteries, both with interposed saphenous vein graft, and it looked great. Certainly was more stressful to dance around that, and I opted to not use a tourniquet, just out of an abundance of caution, which added another element to this case. So if that was not in the picture, say this hand, it was, say the hand is vascularized, your fingers look good in terms of they're pink, they refill well. What's your timing on this? If this is in the ER, and the hand is perfused, maybe one artery's out, maybe the radial's out, the ulnar's in, or vice versa. Is this something that you're just taking right away to the ER? Or are you waiting until your next elective day?
So really interesting. So first of all, I would say I don't recall the last time I had a spaghetti wrist or a full house. I love that. That was complete, meaning everything volarly. And far more commonly, it is one of the vessels is intact. And so if one of the vessels is intact and it's a clean knife or glass type cut, I typically will repair the other vessel. But I certainly don't think it's mandatory if there's good capillary refill. I think that was to your point.
And timing?
I have always done these acutely, either that night or the next day. But there's no reason it needs to be acute. I mean, you don't want the muscle, you don't want to wait 3 weeks, I don't think, because you don't want too much retraction. It's interesting. As you were talking, I was thinking, where do these happen? Like where proximal distal wise do these happen? they happen in a relatively narrow range, and I guess it's just the nature of our anatomy and our susceptibility of trauma. But they're happening sort of in I'm for those on YouTube, you can see, but it's kind of distal 1/4 from the wrist crease, a little approximately, maybe 3 or 4 centimeters. That's where they all happen in my experience.
Right. Yeah. I mean, because at that point, that's when you're dealing with actual tendons, right? Like you go a little more proximal to that, you're dealing with musculotendinous junction or actual muscle injuries, which for some reason don't ever end up either happening there or don't end up being as complete, so to say. So yeah, no, I agree with you. For some reason, they all end up being in this kind of distal quarter of the forearm. And yeah, no, I can't remember the last time I actually had everything out, as was in this case.
Any sense of why vein grafts were chosen? I don't think that would be my initial, plan unless I encountered difficulties with vessel reapproximation.
Yeah, I mean, looking at I guess we'll get into the details, but looking at all of this is the case where if I was feeling a little gutsy, might have been able to primarily repair the nerves. But out of an abundance of caution and the fact the other considerations for rehab, I ended up using nerve autograft. But I think he did us, whoever the surgeon was, they did us a favor by making sure that there was some redundancy in their vascular reconstruction. Because perhaps if they had, really mobilized everything and got those the arteries together, but they were a little tight, that might have limited what I could have done in terms of motion afterwards. And I'm not
Okay.
sure what the decision-making process was. I don't know if I guess I would have thought to prep the leg for Searle, but again, it wouldn't have been my thought to prep the leg for saphenous, like in the thigh saphenous.
Right, right, right. All right. So should we, you want to jump in the technical part and I'll just maybe ask you some questions or we can go back
Yeah,
and forth?
yeah. I mean, I'll tell you. So we opened it,
Well,
and
sorry. What about how did you decide where to do it? Would you have
uh,
done this as an outpatient? Did you feel like you had to be at a hospital or outpatient with microscope availability? What's your thought for a spaghetti wrist?
For me, it's just microscope availability. I think it's fine to do as an outpatient. I think this never comes up as an outpatient. I think this is the unicorn that I saw here. I think there was an expectation that the patient had that was kind of relayed to them that there was some urgency to this, which is not wrong. But they were, in fact, traveling from quite a distance, and we were able to pull something off where we were able to do it on an outpatient basis, but at a facility that had a microscope. To me, I think personally, I would prefer a microscope, although I think certainly this could be done without one. Should you feel so inclined in terms of your magnification with loops. But I do like this under a microscope much better.
So two other questions. Number one, when you got to the operating room, how many days was it post-injury roughly?
6.
Okay. And then my second question is, what did you ask for to have available? So you said microscope. And did you know before you went in that you were going to be doing a nerve graft? And how did you know that? And then the last question is, what type of suture do you ask for in these situations?
Yeah, so my inclination was that we were gonna have to do a nerve graft mainly because it's not, time zero or, day zero, day one after the injury. So my sense was that there probably was going to be some retraction of the median and ulnar nerves, which would make it difficult to get them primarily repaired and coapted to the point where I'd be comfortable moving the fingers and having something glide past the fingers and thinking in the future, in the first 6 weeks about wanting to get some tenodesis going for the fingers. Because I think out of any of the components of this injury, the fingers are probably the most predictable ones. And although I'd like to prioritize the nerve stuff just because of what I do, the nerves still have more guarded prognosis. And, at the very least, you don't want to compromise what you do with your fingers in order to I don't want to compromise the outcome I can get with composite flexion from the flexor tendons because I'm trying to protect the nerves. Because the nerves still it's less consistent. I don't know if that's a mouthful and there's a lot to unpack there, but that's at least how I think about it.
So, we can jump into expectations. So, for those who don't do a lot of tendon repairs, and certainly a therapy perspective here would be fascinating. Spaghetti wrists are, while they can be at the wrong time of day, that is middle of the night, and it can take a while to do all the things that Chris is going to share with us. I think they do pretty well from a nerve. I'm sorry, from a tendon standpoint, what are so meaning I would hope wrist and finger motion are close to full. I wouldn't expect completely full. There will be some strength issues likely. What's your expectation with your nerve repair? So you were going to address presumably the median nerve and the ulnar nerve plus minus superficial branch of the radial nerve.
Right. So SRN is intact, which actually plays into the reconstruction plan for me, which is a niche thing. But palmar cutaneous is out, but was not visible anywhere in the wound. And it's interesting you talk about the therapy component because in preparation for this episode, I dug out an email from my fellowship year that
Wow.
I spent some time with our hand therapists, and I would, when I would do cases as a fellow, I would often ask for their input about, rehab. So I dug out an email from a now retired hand therapist that spent a lot of time in our division, and she emailed me back saying, "Hey Chris, I know there's next to nothing in the literature on the rehab perspective for spaghetti wrist, but I love this diagnosis because it's one where doing the right things early almost always means a happy outcome, and waiting too late to start can cause a little extra misery. Since we're not in zone 2, early active motion isn't as critical. However, if nerves were cut, it's almost always essential to start early digit active range of motion to preserve as much of the brain-hand link as possible." So that's just the beginning of the email, and I still go back to this email because it's actually how I base my protocol for spaghetti wrist with or without nerve. So I just chuckled because that was almost 10 years ago now.
That is awesome. And if we were a little more sophisticated podcast people, and that's on me, not you, there would be a little ding that would happen. So imagine our musical, like, wake up and listen for a second. If you are a fellow or even a resident, and I don't care if it's hand or sports, have a relationship with therapists you trust. And during your training year, during your specialization year, it's not just surgical indications. It's not just surgical techniques. It is understanding what the therapist can bring to the table.
Absolutely. I mean, it's funny. All the fellows seem at the end of the year are scrambling for all the protocol for our various conditions, which I can say I was heavily involved in developing some of my protocols because I work with Athletico more than the Millikan Hand Center just because of the nature of my practice, which was very good for me to learn about kind of how to make these decisions. And I have not thought about them as much because my partners in therapy are so skilled and communicate so well that I don't have to sit there and think about a protocol that often.
Yes, and I had to, I've written a book about therapy protocols for congenital. I haven't thought about sports protocols, but did end up having to write some, which thankfully have been adopted. It's just easier when we all think about it the same way, and we've had those conversations that, as a group of 7, we hopefully we're pretty aligned on how we handle therapy, just because it's better for the patient if we're uniform, better for therapy, and I think we as a group have been pretty good about doing that.
Yeah, absolutely. So, I mean, to that point about the tendons, it is one where I do want to get some passive motion on those fingers ASAP. And then to your question about expectations for the nerve, I think in general, anytime you're involving a nerve graft, you probably have about, based on the literature, somewhere between a 70 to 80% chance at getting meaningful clinical recovery. And typically that's motor, but for obviously these nerves, this is both motor and sensory. So that's a general broad number that I use for patients. I think it sets appropriate expectations. This patient was actually very upfront with what they were looking to do in terms of their future. I won't say specifically what it is for obvious reasons, but they were more concerned about being able to grip and grab as opposed to in their mind kind of the sensation aspects to it, and then the dexterity part of it, which obviously, fortunately, this is their non-dominant hand. But I know the patient has no idea how devastating this injury is going to be to the use of their hand. So I'm trying to paint a picture of what a hand without good thenar and good intrinsic ulnar function looks like for that patient. But you obviously don't want to be too much doom and gloom. So I think it is definitely a very challenging situation to counsel somebody in.
Oh, for sure. All right. So I want to know how long you booked the case for, and I want to know what suture you asked for, both for the nerve and the tendons.
So I committed the sin of booking it for as long as they had.
Well done.
Trust me, I needed to get the case done, so I booked the case as 2.5 hours, and it probably took a little longer than that. But I think this was a place where they actually already had OR time for me set aside, and for whatever reason, a different case canceled, and I was planning on going to that facility anyway. So they were happy that I used the time. Um, and it took a little longer than expected to get in the room and get started because I don't work there all the time. But they were great when I got there. They were very, very helpful. Wonderful team. It's always hard when you're doing a big case with the team you've never worked with, but they were incredible. So then, in terms of, I booked it for 2.5. I probably should have booked it for 3. Knowing I didn't have to do arteries was really helpful, or not anticipating having to redo the vascular part was helpful. I asked to prep the leg because I anticipated harvesting Searle. So in terms of positioning, bump under the hip, non-sterile tourniquets. And I did not put a tourniquet on the arm because I didn't want to be tempted to use it, just given how fresh the vascular reconstruction was. And there's really no evidence. I actually did a lit search quickly, trying to figure out if it was okay or not, because it would move the case along faster. I also asked for some lidocaine with to get through some of the skin parts of it. And then knowing I was going to have to do a carpal tunnel release and Guillain Canal release, I just went ahead and put that Lido with Epi in for that part of it right away, in terms of just to make the initial approach a little bit easier. And I asked for a bunch of suture. So for me, depending on where that is, it's going to be either 3.0 braided non-absorbable suture, and an O caliber of the same variety. And then I asked for my standard microsutures, which for me are 9.0 monofilament. I also asked for some fibrin glue, which is off-label for those listening for use in nerve coaptations, but I think it's a common practice.
Okay, so before we jump in on the technical, which will include order of operations, I'd love to hear how many strands you considered for your tendons, how you think about that in the forearm, and then exactly what you did with your nerves. But let's thank Checkpoint Surgical.
So The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint Surgical is always striving to elevate the clinical practice of peripheral nerve surgery by providing surgeons with new technologies to help improve patient outcomes.
Checkpoint Surgical's newest intraoperative nerve stimulator, the Gemini Bipolar Nerve Stimulator, does just that. With a bipolar stimulation probe, Gemini provides finely controlled stimulation, even at the fascicular level, allowing surgeons to take actions based on the most precise information available. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery. Wow, that is good copy.
Yeah, they have been very great about providing us the copy that they would like. So thank you to the Checkpoint team for that. The nice thing about the Gemini is that there's no chance of stabbing yourself by putting in that grounding needle. But it does have, and this is not an episode about the Gemini, but it does have different features that make it very helpful, and I do like using it for the different features and less risk of stabbing yourself or somebody else.
I need all that. I actually I do a fair number of sciatic nerve decompressions for chronic hamstring avulsions with my sports partners, and I had a 6-month old one, and I actually considered asking for the Checkpoint, but it ended up being fine. So I don't use it with any regularity, once a year maybe, but I know it's important for your practice. Okay.
Did you just say that you didn't use the thing that our sponsor?
Oh, I'm not a nerve guy. I do nerves. I use it, and when I use it, I enjoy it. But I'm being real here, Dr.
Yes,
D.
that's great. Yeah, but this was not a case in which I used that device. It'd be interesting to use a handheld stimulator really early on after the injury to see if you can separate some of your stimulate your distal side before Wallerian degeneration hits. And I've done that for super acute injuries because it's helpful if you're trying to differentiate motor sensory parts. So that anyway, that's an aside. But yeah, so for me, and I'd love to hear your thoughts, what the order of operations are: expose what you can see right away. And I actually ended up doing the carpal tunnel release pretty quickly because it was clear to me that somehow these tendons were cut and retracted back into the carpal tunnel, at least the FDSs and the FDPs. And it was kind of a challenging kind of weaving the tendons back and forth. But the way I generally approach it is, I had to expose these arteries, protect both of the arteries, get a sense of what that reconstruction looked like. And then, wanted to get a sense of the tendons and where the nerves were and what I was going to have to do so that as soon as I could, I'm fortunate enough to work at an academic place like you are, where I have an assistant that I can send down to the leg, start harvesting Searle, which was nice. So as soon as we got the tendons sorted out, and we were at a good place where it was just kind of sewing tendons, I asked our fantastic resident to go down to the leg and start harvesting Searle.
So love that. And agree with everything you said. I don't routinely release the carpal tunnel, although some might advocate for that, just I guess with nerve swelling, so to say. But clearly, if you have to release it, you release it. No second thoughts. I like the concept of putting in a core stitch, not that I think you absolutely have to in this location, and sort of using a tag of some sort to identify the distal and proximal tendons. So that's where the time is spent, identifying, doing your best to confirm you have the right tendon, and putting your core stitch in. And then once you have all that, then you're just tying knots.
Right. So I mean that's the challenge in this case is that my FPL was pretty apparent. That was not hard to get going. My FCR and FC were out, and I did repair those on the way out. And I'd love to know your thoughts about whether both of those are necessary or not. But I went ahead and did it. Did not do the palmaris, but as soon as I could find my FPL, that was the easiest stump to find outside of FCR and FCU. But then all of the flexors for the fingers had retracted back into the carpal tunnel distally. They were pretty apparent proximally. It wasn't hard. I saw my median nerve pretty quickly. And I think one pearl that I was taught and that I was telling our resident was that it's tempting as soon as you see all the anatomy and kind of cut and hanging out to like dissect it out all nicely and separate it, but you can't because you actually need those surface cues of the median nerve at that level is just right underneath the epimysium of the FDS, and that's a super important clue so you know which ones are FDSs and which ones are FDPs. And then you're relying at your carpal tunnel level of kind of the classic, where your tendons are lying in the carpal tunnel. And then obviously you have the cues that use like pulling on the individual tendons to see which fingers are moving. But going crazy and dissecting out everything proximally, it will actually hurt you in the end.
A really, really important point. And then depending on your level, you can choose to repair each of the FDP tendons individually or as a group. Given the fact that they typically have one common muscle belly, there are exceptions to that as well. But I think that's right. You don't want to over dissect this. And so that's why I like just going and putting your core stitches in, and usually sometimes I use a steri strip with labels. But whatever you want to do, just try to leave as much as you can alone, and then start deep, work superficial nerves within that order of operations.
Yeah, to me, it's I think I remember Jim Chang presenting about this. I do like the nerdy part of me wants to do the labels and all this stuff. Practicality wise, repair as you go. If you can repair as you go, like you're saying, putting in your core stitches at least, like that is super helpful to just get things checked off the list because this case will take up as much time as you give it. So if you want to move this along efficiently, you need to kind of get things going as quickly as you can in terms of knocking some of the repairs out.
Yeah, I like the way you said that, because I know when fellows first encounter this in the middle of the night, it can be a really long case. And this is one where you can do a great job, you can do it efficiently, but you have to really focus and go. And so clearly you did that. When you evaluated your nerves, it was clearly, I mean, it must have been apparent that you needed some length. How many strands and how much length did you do for your cable grafting?
The challenge of where this nerve was cut is where the median nerve starts to go from a more tubular structure to starts to fan out to a flatter nerve. So this ended up being, I could have primarily repaired this nerve if I really wanted to keep the wrist a little bit of flexion, but that was not what I wanted to do because I wanted to make sure that I could get tendons gliding past it, and B, get tenodesis going for the tendons. So I actually measured my gap. I trimmed back the healthy fascicles, measured my gap with the wrist extended over a bump and the fingers in extension. So I would be super sure to know what my median and ulnar nerve gaps were going to be. And the median nerve gap was not big. It ended up being about 1.5 centimeters. The ulnar nerve gap was about 2.5 centimeters. So not huge, but so the ulnar nerve ended up being like a really nice kind of 3 cable size from Searle. And the median nerve, just based on the width, was 5. I could have gone 4, but I liked 5. And that's bigger than I typically would use, but it's just because the nerve is fanning out at that point. I wanted to provide a lot of tubes for that nerve to grow down. The tricky part about this one is that I did leave the location of the laceration was proximal enough where didn't coincide with my carpal tunnel incision, and I also did Guillaume's canal release. But there's a skin bridge. And of course, the tendons had to come underneath the skin bridge. They were attracted back in the carpal tunnel. So I ended up putting some sutures in the tendons where I could find them in the carpal tunnel and then pulling those underneath the skin bridge into the proximal wound and shuttling them. And in the process of shuttling them, that kind of disrupted the contents of the topography of my carpal tunnel. So now my median nerve took this like weird turn down and deep. So then I had to do the same thing and essentially reorder the carpal tunnel so that the median nerve was sitting volarly again. So again, had to put like a little 6-proline in the epineurium before trimming back, and then shuttling that underneath the skin on top of the tendons that I already shuttled through. It was so painful, but at the end of the day, I was happy that I'd taken those little things because then the nerve has a much smoother course along the way. And then repairing the tendons, I'd love to know what you do. I was using, and it ended up being a little bit of a kind of a modified Winters Gelderman, but at that point it ends up being modified Kesslers, maybe reinforced with a horizontal mattress, just getting really good stitches, at least force trans in each of them. It's not zone 2, but you still want to get stout repairs.
Yeah, agree with everything. Those tendons can be variable size in that part of the forearm, depending on which tendon you're talking about. And so I agree, it's 4 to 6 strands if you can. Don't mind at all the external horizontal mattress. I think that's a nice way to get a little more strength. And 3.0 to me feels completely fine. I have to say, I don't know that I would have done any shuttling. I probably would have just opened things up. But bravo. Yeah, it's a good case. When do you, and maybe we should close this episode down, but what do you tell the patient? 6 months, a year for quote unquote full recovery?
I'd expect to get the tendons kind of where they should be by about 6 to 8 weeks. That's a little aggressive on the timeline. And then the nerves I always tell people just nerves take the better part of a year, just pretty generically. We won't get into these details, but I did add a sensory nerve transfer from the radial side, the radial distribution on the radial side of the index dorsum to the proper index digital nerve on the radial side, and then for the thumb on the ulnar side from the dorsal ulnar thumb to get some pinch surface going. And that I think is just a way to get things moving earlier in terms of recovery. I have really had no options to do nerve transfer stuff for thenars or for the ulnar intrinsics, so I'm relying on the grafts for that. But yeah, overall the nerves, I tell them, better part of a year, and then hopefully we'll get things moving along with therapy pretty quickly within the first few months.
And you send him to therapy. How quickly do you start therapy?
I'm going to see him back pretty soon, and we're going to do therapy within the first week for finger range of motion. Left the OR in a dorsal blocking splint, for the wrist, forearm-based, dorsally blocking the wrist in neutral, although we did the nerves in extension. And then also extending with outriggers for the thumb and the fingers just to keep them in a position of comfort. So then we'll start some passive motion for the fingers pretty soon.
Love it. Love it. Okay. I'm sure it's interesting. You and I probably underestimated how much there was to talk about here, but I think we got most of it covered. We could certainly, those sensory transfers are interesting, but maybe for another episode.
Yeah, it's super niche, super nerdy. No,
Yeah.
yeah, we can definitely talk about it another time. But
Yep.
yeah, no, I love this case. It's one of those things that's fun to do while you're doing it. You just don't want it to take too long because then it becomes less fun.
That is exactly right. All right. Well, this has been fun, and look forward to talking next time.
All right, catch you next time.